So yesterday at my oral presentation about applied precision cancer medicine in biliary tract cancer in a metastatic setting, all in all we included in our platform for precision cancer medicine 30 patients, 16 men and 14 women, and we identified in these 30 patients who were all in a metastatic setting 35 molecular alterations. And the most frequent alterations were seen in KRAS, TP53, IDH2 and IDH1. We had also 2 cases of BRAF mutation. One of them had a BRAF V600E alteration and was included in the ROAR phase 2 trial, and for I think 2 months ago Weinberg et al. Had a sub-analysis of the ROAR trial which showed disease control over 80% for patients who were treated with dabrafenib and trametinib who had a BRAF V600E mutation. And in our platform we could suggest in 60% of all cases, so this means 18 persons, we could suggest or recommend a targeted therapy based on their specific molecular profile. And the molecular profile also included the immunohistochemistry, which revealed a overexpression of EGFR and phosphorylated mTOR in the majority of the patients. So over 25 of the patients had EGFR or phosphorylated mTOR, and 4 patients had HER2 expression, and notably 6 patients had an overexpression of PD-L1. So that's remarkable, because these are druggable alterations which can be targeted, for example, by trastuzumab, pertuzumab, or by, and PD-L1 can be targeted by immunotherapy, for example, by pembrolizumab. So our analysis was primary a feasibility analysis. We wanted to show that nowadays it's quite possible, technically feasible, to perform precision cancer medicine analysis for patients for whom we do not have a standard therapy regimen anymore. And we wanted to show that, and the concrete numbers are that from the time of analysis, from time of biopsy to the mapping of the molecular profile, we needed 18 days. And from time of biopsy to the initiation of the recommended targeted therapy, we needed a little bit more than 3 weeks, so exactly 23 days. So this means that nowadays it's implementable and applicable into clinical routine. That's possible. In 7 patients, we could apply the targeted therapy, so eventually 7 patients received it. Unfortunately, 3 patients died prior to restaging, so 4 remained, and out of these 4, 2 had a disease control, and the 2 other experienced progressive disease. What I want to stress and point out that this analysis was not interventional prospective trial. It was a feasibility analysis of our platform of precision cancer medicine. And these, I mentioned the turnaround time from biopsy to analysis and to the initiation of target therapy to give you an overview about the possibility nowadays. But this also shows a disadvantage of biopsy, because it takes a lot of time so that you can perform the biopsy and perform the molecular profiling and to eventually recommend or initiate the targeted therapy, because we always have to discuss the results in a multidisciplinary tumor board, and we see or we check whether we can offer a target therapy or not. And it would be better in the future to maybe avoid biopsies, to reduce the turnaround time from 3 weeks nowadays to maybe only 1 week, to initiate the targeted therapy at an earlier time point, because particularly in this quite rare entity, the prognosis is quite dismal and poor. Despite therapeutic efforts, the prognosis of biliary tract cancer in the metastatic setting is below 1 year. And when several weeks passes and you cannot offer a targeted therapy, the health condition of these patients aggravates, and you cannot initiate the targeted therapy due to the deteriorated health condition. That's the problem. So in future, it would be great if we can have a follow-up molecular liquid biopsy to, on the one hand, to monitor the therapy response by, for example, assessing the tumor mutational burden, and on the other hand, we could reduce the turnaround time to see whether the therapy is have an effect or not. Regarding the costs and expenses in precision cancer medicine, I can tell you that at our center, the expenses are covered by the general hospital when the patients are in a setting for whom we cannot offer a standard therapy regimen anymore. And for those patients, the general hospital is willing and is ready to cover the expenses for the mapping of the molecular profile, which includes the gene sequencing, which includes the immunohistochemistry, FISH, and the RNA fusion panel for detection of gene fusions, which is quite important for metastatic biliary cancer, because FGFR2 gene fusions are typical of intrahepatic cholangiocarcinomas. I think in the future we will have the possibility of novel therapies which are molecular driven and tissue agnostic therapy approaches. We will target in a specific manner FGFR2 mutations, BRAF V600E alterations, and also IDH1 and IDH2. There are upcoming drugs, and we will apply them in foreseeable future to help our patients. What I also think will play a significant role are cell adhesion molecules, which are also subject of intense research focus. And we will have, I think, in the future drugs which will target cell adhesion molecules and will maybe help to improve the outcome in these patients.